So the metastasectomy for renal cell carcinoma, I wish I'll be able to give an answer, and I'll do my best. But as we know, up to 25% of renal cell carcinoma will have metastases, and about 40% will develop metastases. So we're looking already at two different types of population. Some are with synchronous and some are with metachronous metastatic disease in renal cell carcinoma. 5-year survival is known to be quite low, and mets from kidneys go virtually to any organ: lungs, lymph node, liver, bone, brain, pancreas, thyroid, skin, anywhere you want. If you look at NCCN guidelines and you look at this very group prior to directing them to this whole crew of medical therapies, if you look at these stage 4 relapse patients, and if you just zoom in on this, we need to understand that these are not the same patients. Just because NCCN people who wrote the guidelines put them in this very basket, we need to understand that we're looking at a very mixed basket, and of those of us who recently learned English of apples and oranges. And as we understand, there will be some apples, some oranges, and some very ugly oranges that those will indeed go on killing. Yet there will be some friendlier guys and some stupid clones that will make it into mets and will sit dormantly. So when we talk about metastasectomy, we need to look at indeed a few sites and a few issues. What is the primary tumor? How big was it? And what kind of histology did we deal with? Patient factor. Is it synchronous or metachronous disease? Perhaps the most important point. Location and number of metastatic disease. And what are the patient characteristics or markers? And when we start reviewing it, we can take a look at what this tumor stage is and where the sites of disease were and what are the parameters and performance status and age. And of course, the other associated problems of perineoplastic such as ascites or pleural effusions. So we all know that removing tumor is great, but even the role for cytoreductive nephrectomy is still undefined. And what are we going to do trying to identify when are we going to not only remove now the tumor, we're now going to talk about the very next step of removing metastatic sites. It's important to realize that when we have patients who present with synchronous metastatic disease, and if you look at those that have a intermediate risk group, you look at the overall survival, it's very low. Intermediate and poor risk group, look at this, 5 to 8%, and then 14 to 15.5, and this is the modern era, and most of those patients did undergo cytoreductive therapy, and most of those did undergo secondary therapies. So, and we know already about the Carmina trial and the RTC upcoming trial, just to define again overall of cytoreductive nephrectomy. But the concept is indeed very important, that the removing of the tumor and removing of the larger body of the tumor is quite advantageous. Outcome after cytoreductive nephrectomy is predicted by functional percentage of tumor volume removed. We saw that paper. Tumor burden is an independent prognostic and metastatic, and associated of percent of tumor with the bulk in nephrectomy. So once again, idea of tumor removal is important, but let us not be stupid. When we look at this T4 type of renal cell carcinoma, and when we look at this scan of the liver, I don't think that many of us are actually contemplating of idea of a metastasectomy in this very patient. Yet this was one of my patients who presented, and we did a left radical and we did a lymph node dissection. He did have an N1 disease, and then of course 3 years later he has this lesion. Well, perhaps before throwing the poisons at him, we can perform a metastasectomy. Interestingly, he presented later, he has this radiolucency 3 years later. So we continue to disassemble this, and that indeed he later had this patient. We have a patient, we've written that the patient is 16 years out of progressive disassembling part by part. We changed the transmission, we changed the oil, the tires. This patient is still running. So if you look at this patient who presented, for example, with this large renal mass and this retroperitoneal lymph nodes quite extensive in the aortic cave. So what do we do? Do we just remove the nephrectomy? Do we just perform the nephrectomy, or we proceed with lymph node dissection? In this case, would be considered to be metastasectomy. We did it with a robotic. You can see very large bulky nodes were removed, very large tumor. But again, the reason we are showing this is because if you look at the scoring algorithm from the Mayo Clinic, the Leibowitz is indeed providing a very important piece of info with their colleagues. You can see that the score of -5 to 1 are the ones that do the best, and you can see they at 3 years They're way past 60%. Well, what gives us this -5 score? Complete resection of metastatic RCC. So if we are able to resect the metastatic disease completely, of course in selected patients, these patients will do better. There are numerous papers, and I do not have enough time to go over all of them, although I will briefly touch on different organs where metastatic disease occurs and how these patients do. This is meta-analysis of pulmonary metastasectomy. And take a look at number of patients, very large number of patients, over 372 of regional lung metastases. And take a look, complete resection, 5-year survival, 54, 44, 42%. This is by far better than any TKIs or any available methods of treatment that we have so far. Treatment of osteometastasis, again, identifying the right patient with solitary osseous metastasis appear to be doing better. Systematic review of pancreatic surgery, 311 patients that were surgically treated, and of course there were some that probably were disasters that were non-surgically treated. But take a look, in those appropriately selected patients, the 5-year overall survival following metastasectomy was in their study 72.6%. Hard to believe, but indeed that's what they've shown. Surgical resection of carcinoma of brain metastases in 50 patients. It's also very controversial. Some studies show that brain metastasis is a death sentence, that it's a 3 to 4 month. In some studies, they go ahead and resect brain metastases followed by a whole brain radiation therapy or just multiple brain metastases, and some patients appear to do well. So we need to identify the thyroid metastasectomy. I co-authored one of these papers on liver-directed therapy. We wrote a small paper from the review of the NCI, but the cases for the review of the gallbladder. Look at all these cases documented with the metastasis just to a gallbladder. Who would think when we saw 4 in a row? And I know that Dr. Totan already talked about this paper, but I think we should spend a few more minutes talking about this paper by Alt, because I think it summarizes the concept of when metastasectomy should be performed, on which patients, and what kind of metastasectomy should indeed be done. So if they looked at 30-year experience from Mayo Clinic, they had 887 patients with multiple metastases. Some presented with synchronous metastatic disease, some presented with localized disease, 60%, and of course, some of them have developed. So as you can see, some are synchronous, some are metachronous. Some were chosen to undergo complete resection, and some did not undergo complete resection. And you already saw it, but that's very important. There is no question that there is a selection bias, and I'll show it to you. But if you identify those patients that had the tumors completely resected, they can do very well, and you can see at 10 years, as many as 50% are alive. This is better than any TKIs that we have. Interestingly, all patients with multiple metastases, and again, I'm talking about multiple metastases. There are no solitary metastases in this series. So if we look at this, this is for lung only, and with complete surgical resection, without complete surgical resection. And again, notice how the cancer-specific survival and the overall survival are actually almost identical curves, because we do know that patients from renal cell carcinoma die from this disease, and their overall survival is identical. Take a look at the comparison of group, those that underwent metastasectomy versus those who didn't. Well, it just shows that as physicians, we are just pretty good in terms of identifying who needs to have metastasectomy. The ECOG was different, the location of metastasis were different, the timing for metastasis were different, the number of sites were different. So these were certainly not similar groups. So we should not be just saying, no, absolutely, do metastasectomy in everybody. But there are, of course, there are some selection biases. There were different histologies. As many as almost 50% received additional systemic therapies, and some received radiation. And those who presented with synchronous metastatic disease did not benefit. And I think it's important to understand, when we think of metastasectomy, please think of this metachronous disease. Those probably are ideal patients, not necessarily those patients that come with the disease. So if you look at lung only, look at this. Almost 60% at 10 years with complete surgical resection. Again, this is lung only. But even though then when we say, well, if they're not lung, there is no point in resecting them. Here we go. This is for non-lung. Almost 30% with complete surgical resection. Again, this is multiple metastases. So what are the common themes, and how one should think of selecting patients for metastatic RCC who may benefit from metastasectomy? Who do we select? Who are the patients who may benefit? Look at the disease-free interval. If they're a year or more, and there are some studies that suggest that, of course, there were no differences, you can do even on synchronous setting. But the longer the disease-free interval, the better of your chance that these patients will do well metastasectomy. Look at their performance status, if they can tolerate it, if they can undergo multiple resections from different organs, this may still proceed with that. Sites of disease, brain versus lung. Of course, if one has brain, bone, and liver versus a few small nodges in lung, those are not going to likely to fare as well. Nevertheless, take a look at them and don't exclude those just if they have a brain metastasis. I went again to Wisdom. I treated a patient with a brain mets. I gave him SBRT. We gave him the gamma knife. We removed the kidney. Patient is 5 years out and still alive. Number of metastatic lesions. Again, look how diffuse disease and think if you can perform and you can get the team who is willing to perform with complete metastatic resection. Our thoracic guy will go after 10 lesions without blinking if we feel that they appear late and that we can still go and do some for this patient. So final thoughts. Consider metastasectomy, especially if metachron is disease. Survival analysis for selected patients treated with metastasectomy are superior to any TKI trials or available drugs. And that's indeed a case. So surgery may still be very curable. Consider metastasectomy even in the setting of multiple metastatic sites. Please do it cautiously, don't subject everybody, but select your patients appropriately. Formalin is still the best drug for renal cell carcinoma. Thank you.
So one question only because we are lack of time.
Thank you, Gennady. Excellent talk. Recently, we had several referrals from our oncologists, patients with multiple met sites, relatively stable after nephrectomy and TKA, but there was some exclusive site, mainly in an adrenal when you have growing mass.
But where was the site?
Adrenal.
Adrenal.
So is there a ratio operating on this exclusive site when you can't do complete metastasectomy in every site, but to take out this growing site?
I'd like to use evidence to answer your question. I think there may be a shot for these patients. I think this is a different metastatic clone. While there is most of the literature suggests that this is one single clone that goes metastatic, this may be a very different animal. Either it's a different seed or it's in a different soil, and if that's the only site of growing and that's of the growing disease, there may be a reason to do so. So we would probably discuss it with the patient. I don't have the evidence to suggest what I just said.
Next speaker, Dr. Levent Turkeri, when and where to apply metastasectomy in bladder and prostate cancer.
Thank you, Mr. Chairman. I'd like to thank Professors Jakob Ramon and Larry Klotz for their kind invitation. It has been a great meeting, and I'm very happy to be here among with you. Today, I would like to talk with you the role of metastasectomy in the bladder and prostate cancer. This is not very well defined, as in the case of germ cell cancers, and as you heard from Dr. Bratslavsky in terms of some renal tumors. Because the treatment benefits of metastasectomy in bladder or prostate is still remains uncertain, and the only evidence that we have is coming from some small case series. So most of the things that I'm going to talk about today is going to be level 3 or 4 evidence, and probably they are not going to make it up to the guidelines. In terms of non-seminoma germ cell tumor, the treatment of metastatic disease is quite standardized because you start with primary chemotherapy and then resect the remainder of the residual masses wherever you see them. And this has been clearly shown to improve the disease-free survival and overall survival of these patients. However, in urothelial carcinoma, the standard of care in metastatic disease is chemotherapy followed by observation of the patients. And we know that the recurrences are mainly at the site of the primary metastatic sites, and these patients are going to die because of the progression of these sites. And this may be a sign of persistent active malignant cells at those locations, and that may provide a further basis of metastasectomy in order to improve the prognosis of these patients. When we look at the literature, in fact, there has been some small case series where the authors tried to remove the metastatic sites, mostly in the lungs and the lymph nodes, and they achieved a 5-year overall survival rate roughly about 35%. There has been a recent article in European Urology from a multi-institutional series in Germany, and they looked at 44 patients where they have removed the metastatic sites, mostly again in the retroperitoneal lymph nodes or lungs. And what they have shown that after metastasectomy, the median cancer-specific survival was about 34 months. And only 15% of those patients survived more than 2 years. So we are talking about a certain group of patients which may benefit from metastasectomy. These investigators could not identify any prognostic factors that could define the best candidate for metastasectomy, but what they have shown or observed was that if the patient had a good response for the prior chemotherapy, if they had limited metastatic disease, and if all the metastatic lesions were completely removed, then this may be associated with an improved overall survival. And actually, this is the reality for most of the metastatic cancers at any site. There was another very recent article from Japan, again a multi-institutional study where they looked at 42 patients and achieved almost exactly the same results as German series, where the 5-year overall survival after metastasectomy was about 31%, only 29% of the patients were alive after 2 years. However, further analysis of their data identified a subset of patients which may benefit very well from metastasectomy, and these were the cases where there was only solitary lung metastasis or lymph node metastasis. The median survival was 81 months compared to 19 months for the rest of the patients. So obviously limited metastatic burden is a good prognostic factor, which is in fact in line with the literature coming from thoracic surgery community. In case of thoracic surgery, as you know, removal of metastatic lung metastasis from different organs is quite common, and urothelial carcinoma has been reported in some series, and where they found that the overall survival at 5 years is about 50%, and if the metastasis was solitary, the 5-year survival can reach up to 85%, which was clearly in line with the findings of the Japanese group. So the limited number of lung metastasis is clearly a good prognostic factor. In one study, a multivariate analysis identified the size of the lesion as well as a prognostic factor, and if it was smaller than 3 centimeters, those patients had a 5-year survival of about 60% compared to 10% of the rest of the patients. When we talk about prostate cancer, the usual presentation of metastatic disease is with multiple bone metastasis. Single bone metastasis is quite rare. Solitary pulmonary metastasis is extremely rare, as has been clearly shown from clinical studies where the isolated pulmonary metastases were seen in only less than 1% of the clinical series, and again less than 1% at the autopsy series. In fact, a recent literature search has only identified 18 solitary and 15 multiple isolated pulmonary metastatic cases, which was published in the literature. So we are dealing with a very small group of patients. However, the surgical excision could be performed in less than 20% of the cases, and again, less than 20% of these patients benefited from the treatment, although the definition of benefit was not uniformly defined. One point worth mentioning is that those patients who benefited the most were either solitary metastatic or oligometastatic disease. This has been another study from Italy, although this is not exactly the metastatic concept that we have in our mind. These patients were after radical prostatectomy. They had abnormal PET-CT scan and in terms of lymph node metastasis, and the authors went on and to remove the metastatic lymph nodes, and they have shown that if the PSA was less than 4, or if the pelvic lymph nodes were positive compared to the retroperitoneal lymph nodes, those patients did much better compared to the rest of the patients. But we don't know what would be the result if there were bone metastases in those patients, and clearly that requires further investigation. Today's paradigm in prostate cancer is that there is a limited time life expectancy depending on how you define the limited term, and the resection of metastatic sites at bone or viscera is only limited to the patients where the symptoms cannot be controlled by other means of management, and if they are a direct threat to the bodily functions, which I think is a quite rare group of patients that we are talking about. The resection of metastatic lymph nodes, this group appears to be the ones who benefit greatest from surgery, and obviously we need more effective systemic therapy, as you heard from the previous speakers, that it is on the way because we have new drugs. Probably with more effective systemic management, we would be more aggressive in removing the metastatic sites. I think today's paradigm shift is not removing the metastatic sites, but treating the primary, as you heard from Dr. Fleischner's talk before, and more in bladder and in prostate, people are interested in removing or treating the primary site in metastatic disease rather than removing the metastatic sites. This is a SEER database study, and they have shown that if you treat the primary site by radical prostatectomy or brachytherapy, you achieve much better overall survival compared to the hormonal therapy alone. So I think cytoreductive therapy in bladder or prostate, whatever, with or without resection of metastatic lesions, may improve the disease outcome and improve the survival, and definitely warrants further investigation, and that is what is being done in many institutions in Europe, in North America for the time being. Thank you for your attention.